Thank you very much. Thank you. First of all, I would like to really thank the organizing committee for giving me this opportunity. I'm sorry I could not make it to Murree because of some university assignments, but thank you very much for the honor for this presentation. I would start by saying that an interventional cardiac cath lab has become an important component of the management of children and adults with congenital heart disease. And there has been major advancements in the last decade. And these advancements are complemented by advancements in imaging, and especially 3D imaging has really revolutionized the way we look at things in cath lab anymore. And some of these procedures have become standard of care, while for others, I think the benefit remains unproven. My talk will be really an update on these interventions and a brief on the modalities, outcome, and challenges we face in congenital heart disease interventions. If you look at the list of these procedures, I think it will be impossible to go through the entire list. So what I've done is that I know that Brigadier Khurram is here and he's going to talk about transcatheter pulmonary valve implantation for the native right ventricular outflow tract. What I will be focusing upon will be three major interventions or three major advancements in the field of congenital heart disease. One is transcatheter closure of sinus venosus atrial septal defect. The other one is fenestrated atrial devices for pulmonary arterial hypertension, particularly in the context of atrial septal defects, and the availability of newer devices for transcatheter VSD closure. Of course, there are major other advancements like device closure for PDA in preterm babies. We have certain fetal interventions. We are doing lymphatic occlusion for plastic bronchitis and protein-losing enteropathy in patients who has had Fontan. And of course, there are three-dimensional imaging to complement complex congenital interventions as well. Let me start with the transcatheter closure of sinus venosus ASD. All of us know that secondum ASD closure has become a standard of care already. And this day and age, 80% of the patients who actually have a secondum ASD would go for transcatheter closure. But more recently, many children who have a sinus venosus ASD are also being subjected to intervention. And I think, let me sort of clarify the anatomy once more. The superior sinus venosus defect is anatomically distinct because it represents a deficiency of common wall between the superior vena cava and right upper pulmonary vein. So rather than being a true ASD, it's actually an unroofed right-sided pulmonary vein, which anomalously drains into the SVC right atrial junction. And the intervention which is now being done is that a covered stent is being placed in the superior vena cava that will allow pulmonary venous return to be directed into left atrium and closure of sinus venosus ASD. Let me show you how it is done in the cath lab. You can see the catheter being advanced to the superior vena cava. Then you actually make sure that you actually have clear evidence of the anomalous pulmonary venous drainage as well. You go for an angiogram and delineate the superior vena cava very clearly. One of the most important things is actually balloon interrogation of superior vena cava. And the reason we do that is, of course, you need to make sure that how much you can actually dilate that SVC. So what is the stretchability and what size balloon do you need to actually dilate that SVC and make sure that that stent actually is anchored there. Of course, this is done in addition to balloon interrogation. We also use the transesophageal echo and simultaneous angiography, as you can see over here in this particular picture. Now, the next step, you can see a long, this is a custom-made 10-zig long stent which you put into the superior vena cava. You need to make sure that your catheter is also in the anomalous pulmonary vein, and then you start dilating this stent, and you can see in the bottom picture that the stent has been completely dilated by using a balloon. Now, what is also important is because your SVC is actually coming into the right atrium, and right atrium is obviously a much larger structure. So it's important that you actually flare the lower end of the stent with another balloon to oppose to the septum so that it does not go down or it does not embolize from its position, as would be a possibility in these patients. Now, this is another patient, and this stent migration can be actually stopped by using an overlapping stent, as you can see over here. If you do not have a custom-made long stent, what you do is that you put in a relatively short stent in the upper part of the SVC, and then you use a second stent which will partly overlap the first stent, and then you dilate that stent, as you can see over here in this particular picture, and that will actually take care of the entire sinus venosus defect and also will actually decrease the incidence of slippage or embolization. Now, one important consideration here is that you need to monitor the right upper pulmonary vein and left atrial pressure simultaneously to make sure there's no pulmonary venous compression. Because in most cases, the LA and right upper pulmonary pressures would increase because there's a change in LA compliance. But you need to make sure that this graph is available to make sure that you actually do not compress the right upper pulmonary vein. And you can protect the right upper pulmonary vein. You can use a separate balloon. As you can see here, an Atlas balloon has been used to actually protect the right upper pulmonary vein from being compressed by the stent which has been put into this sinus venosus defect. Now, the largest experience, we have a very limited experience of few patients over here. The largest experience comes from Evelina Children's Hospital, and I'm thankful to Professor Sir Shakil Qureshi for sharing the data with us. They have done so far 50 patients, age range from 15 to 78 years. And you can see acute complications in two patients. One, a post-procedural hemopericardium, which was drained, and the second one, a stent migrated, and they had to put in a second stent into that. Coming to the second intervention, which really has revolutionized the way we look at ventricular septal defects anymore. Historically, what happened when we started doing VSD closure, there was a high incidence of complete heart block. People would have aortic and tricuspid valve damage, and that raised serious concerns showing or actually halting the procedure, especially in the West. But it really continued in the East, and we know that in Eastern countries, we have a very higher incidence of infective endocarditis. But what has really changed the outlook of VSD closure more recently is the availability of newer devices, which I have shown over here, an MFO device, a soft ADO2 device, and NIT-occlude VSD coils, because these softer devices can be delivered both antegrade and retrograde. They have low profile sheaths, and they reduce the risk very significantly. Let me show you an MFO device. It's a very soft woven mesh, self-expanding device with two discs joined by an articulate waist. You can see over here, this is an ADO1 style, and this is an ADO2 style. Each disc has a hub on the external surface, so you can put in it from either side, either from arterial or from venous side, and that has actually changed the perspective. Let me show you the device over here. It has two components. The one which is shown over here is ADO1 type, and this is ADO2 type. If you actually feel this device, you will be surprised how soft this device is, and the connecting waist actually gives you a lot of leverage, as you can see over here. Now, you load that MFO device to a very soft cable, as you can see over here. The cable is very thin and soft cable, and it allows you to actually do that in a very logical way. Let me show you an example over here. This is a large ventricular septal defect in a 20-year-old who was referred to me by an adult cardiologist. You can see on transesophageal echo, it's a large defect. You can see on the short axis and on the long axis as well. This was a 10 millimeter ventricular septal defect, which had been missed, but fortunately covered by the tricuspid tissue. Normally, covering by tricuspid tissue would be a contraindication to device closure. But with the advent of this softer device, which I just showed you, it was possible for us to actually close this defect. And you can see on the right side over here, an angiogram it has been crossed retrogradely, and a 1214 MFO device has been used to close this defect very nicely with no residual VSD across it. Another procedure, I think, which has really changed perspective of VSD closure, and I'm thankful to Khurram for sharing this particular videos with us. This is used in small defects with large, small infants with large defect. Your surgeon would have opened the chest up. You can actually directly puncture through the right ventricular wall and enter into the left ventricle through that ventricular septal defect by placing a sheet there. And you can see a large VSD device has been placed across that VSD. Another modality in terms of VSD closure is muscular VSD in apical VSDs. As you can see, a very large apical VSD over here. The surgeon has already placed a PA band when the child was an infant. Now this is a 5-year-old who has come in, and you can see we have closed this ventricular septal defect by using a 12 size muscular VSD device. And then the surgeon went in few hours later and took the pulmonary artery band away without actually putting this child on pulmonary cardiopulmonary bypass. Lastly, the third procedure which I wanted to mention here is fenestrated atrial devices in the setting of pulmonary hypertension. We all know that despite remarkable advances in pharmacotherapies, we still have only 5-year survival of about 50% across all subtypes of pulmonary hypertension. And in severe pulmonary hypertension of whatever etiology, we know that creation of an interatrial communication has shown to improve symptoms and functional status. And the resultant right to left shunting not only improves LV preload and cardiac output, but it decompresses pressure overload RV, resulting in improved RV function. Of course, these patients get a little bit desaturation, but you improve their functional capacity and long-term outcome. And look at this atrial flow regulator, which is used. It's available in disc diameters with fenestrations varying from 4 to 10 millimeters in 2 millimeter increments, and has also been recently CE marked. And I think several studies have now reported successful use of this AFR in patients with severe pulmonary hypertension, in patients who are severely symptomatic, and there you can see a significant improvement. But I think what is more relevant in our setup is actually the interatrial shunt device. Now look at this device. This is a classical ASD device, but what you can see over here is a large fenestration within this defect. Now in our setting, this device has a very special place. Many of our patients are undetected as a child. They grow on to develop pulmonary hypertension in the setting of a large atrial septal defect. And we know that many of them would actually improve not only clinically, but also in terms of regression of pulmonary hypertension if we partially close that atrial septal defect. And we were also part of this large multi-center study where this compassionate use was in the first instance used. We reported that data in the literature as well. And now, more recently, a single center study has also shown that patients who have significant pulmonary hypertension in the presence of an atrial septal defect, if you start treating them with pulmonary vasodilators and then you bring them back to cath lab and create close that ASD but leave a fenestration. Of course, the surgeon can also do that, but doing it in cath lab is far less riskier than surgical procedure. And we have shown in our data too that majority of these patients not only would show regression in pulmonary hypertension, but show significant clinical improvement even if the pulmonary artery pressure does not fall. So I would like to conclude by saying that transcatheter interventions in congenital heart disease is really a rapidly advancing field. The past decade has witnessed a remarkable development in existing techniques and emergence of novel alternatives to treat an evolving number of cardiac lesions who were traditionally dealt by surgeons. And these cardiac interventions have evolved from what people thought was an adventure to a robust subspecialty. And we know that adult congenital heart disease is also now a developed subspecialty providing percutaneous treatment for a larger number of lesions from fetal life to adulthood. And some of these procedures are now standard of care, although some are still, I think, needs to be proven and are in evolving stage. And I think the continual innovations in techniques and devices, they hold a great promise for personalized therapies that may alter the course of disease progression and lifetime management strategies for patients with congenital heart disease. Thank you very much. And I will be happy to answer any questions.